Swayam Prabha. Digital India. Educated India.
Diseases of adrenal gland. Adrenal gland is the perfect example of how the endocrine organs are working. There is source of trophic hormone which is released from the pituitary, which is in fact under the control of some releasing hormone from the hypothalamus. Then this trophic hormone, they stimulate the adrenal gland and produces steroids which act on the target organs. Whenever there is levels of these steroids, they increase, there is suppression of the trophic hormones, which is the ACTH, and the level decreases. So how these endocrine organs, they control by the feedback mechanism. Adrenal is the best example. In fact, there are two adrenal glands, right and left. Both are slightly different in shape. Both of them, they lies at the upper pole of kidney. That is the reason they are also known as the suprarenal gland. In fact, each adrenal gland is composed of two glands, cortex and medulla. Both of them are actually derived from different germ layers. So there are two endocrine glands which fuse together to form one adrenal gland. Adrenal gland is composed of cortex and medulla. The cortex is the predominant part. The medulla is the very thin, comprises less than 10% of the total thickness. The cortex has three layers which produces the aldosterone. The other produces the cortisols, and the third layer produces the sex hormones or sex steroids. Medulla produces the catecholamines, and any tumor or lesion can arise from these different layers of the cortex or from the medulla. In fact, if you see the causes of the hyper functioning of the adrenal gland, there can be hyperfunctioning, there can be hypofunctioning. The most common cause of hyperfunctioning, what we call as the Cushing syndrome, is the exogenous administration of the steroid. That is the most common of hyperfunctioning. The steroids were given for large number of diseases as a part of treatment. These steroids, they causes the hyperfunctioning and they suppress the ACTH levels, and due to suppression of the ACTH levels, there is atrophy of the cortex. That's the most common cause of hyperfunctioning. The other causes are the endogenous causes, and of the endogenous causes, something may be wrong in the pituitary gland, which is classically known as the Cushing disease, whereas if hyperfunctioning of the adrenal cortex is known as the Cushing syndrome. Cushing disease, usually the most common cause of Cushing disease is the pituitary adenoma. The other may be, very rarely, maybe hyperplasia or pituitary carcinoma. The other causes may be the ectopic production of ACTH, or maybe something wrong in the adrenal cortex, which may be the neoplasia, that is the adenoma, carcinoma, or sometime it may be the hyperplasia, which may be macronodular hyperplasia or diffuse hyperplasia. It may be associated some with the syndrome, which are genetically determined. There may be some mutations which causes hyperfunctioning. This shows the causes of the Cushing syndrome. As I mentioned, the most common is the iatrogenic, that is the steroid which is given for different diseases. The other causes can be predominantly are pituitary. About 70 to 80% of hyperfunctioning of the Cushing syndrome are the pituitary adenomas. There may be adrenal, which are the adenomas, about 10 to 20%, and in less than 10% of the cases may be ectopic production of ACTH. Now this shows the most common, as mentioned, is the pituitary adenoma. Most of the time the pituitary adenoma, which causes the excessive ACTH secretion, which act on the cortex and causes the Cushing syndrome, they are microadenoma. They are very small, but they are functional and they are detected early. Microadenoma we call when its size is less than 10 mm. Rarely the ACTH secreting adenoma can be macroadenoma. They are more common in female as compared to male. Rarely there can be hyperplasia of the ACTH secreting cells in the pituitary gland. The other causes How to differentiate the Cushing disease or the ACTH dependent Cushing syndrome from the ACTH independent Cushing syndrome? Now, if you give the steroid, which is known as the dexamethasone suppression test, if you give the low doses of dexamethasone, in the ACTH dependent, that is something wrong in the pituitary gland, the levels are very high. You give dexamethasone low doses, but it will not suppress the ACTH secretion. But when the doses are increased, what we call it the high dose dexamethasone suppression test, then it suppresses the corticosteroids, and which can be measured in the as a metabolite in the urine. In case of ACTH independent causes, which is the ectopic, many times there can be ACTH which is produced by the tumors. For example, some carcinoid of the lung or pancreas, or the small cell carcinoma of the lung, or medullary carcinoma of the thyroid, they can produce the ACTH, but which is not suppressed by the dexamethasone test. So this is ACTH independent. And the treatment for these cases is the surgery of the primary tumor as compared to the pituitary adenoma, whereas the surgery of the pituitary adenoma. In the ACTH independent, whatever doses you give of dexamethasone, whether low dose or the high dose, there is no effect on the cortisol levels, which I already mentioned can be measured in the serum, or their metabolites can be measured in the urine. Now this is the example of the carcinoid tumor in the lung, which was producing ACTH, and this is the immunostaining for ACTH. These brown color, these cells are positive for ACTH, and these cells are also positive for the corticotroph releasing hormones. It indicates that this hormone is released by the cells which act on the same cell, maybe the paracrine effect, and causes secretion of the hypersecretion of ACTH, which act on the cortex of the adrenal gland. The signs and symptoms are variable, but in vast majority of the patient, the typical features are Cushingoid faces, typical moon faces. There is a deposition of fat on the cheeks, around the eyes, around the back or neck, what we call the buffalo hump. There may be hypertension, diabetes mellitus, osteoporosis, muscle weakness. But the most typical feature is the central obesity, and there is proximal muscle weakness. There is stretching of the skin, and the vessels are very prominent. These appear as the stria on the abdominal wall. Now, depending upon whether the adrenal gland is involved or not. For example, in the pituitary adenomas, ACTH hypersecretion causes the hyperplasia of the adrenal cortex, what we call the hyperplasia of the cortical hyperplasia. In the tumor which are secreted, which are in the adrenal and secrete the cortisols, the ACTH levels are low. So the opposite adrenal cortex or the adrenal cortex adjacent to the tumor may be atrophic, which helps to some extent to differentiate between the different conditions. In the hyperplasia, the normal adrenal weight is about 3 to 5 grams, and on average it is 4 grams. The combined adrenal weight of the two glands will never cross the 10 grams, and if it is more than 10 grams, it is indicative of the hyperplasia. Hyperplasia may be diffuse hyperplasia, the whole of the cortex is hyperplastic, or it may be nodular hyperplasia where there is a nodule formation, and sometimes these nodules can mimic the benign tumor adenomas. So it is very important to differentiate the nodular hyperplasia from the adenomas. Now this hyperplasia depends upon which part of the adrenal cortex is involved. If it is the glomerulosa, it may secrete the aldosterone. If it is the fasciculata, there is hypersecretion of the steroids, corticotrophs, or it may be hyperplasia of the reticulata, which produces the sex hormone. Or there may be even in the one there may be hyperplasia for all the three layers, or one may be predominant. This shows the adenomas usually well circumscribed, encapsulated, and they may be composed of one types of cells, which is predominantly some steroid producing cells, which appears as vacuolated, or maybe the fasciculata or reticulata like cells, which are more eosinophilic. Now, to differentiate between the adrenal adenomas and carcinomas, sometimes it's very difficult, but in majority of the cases, one can differentiate based on the sum of the features. Adenomas are usually well circumscribed. They may be encapsulated. The carcinoma, as compared to adenomas, are poorly circumscribed, but they have a thick capsule. In adenoma, usually the weight is less than 30 grams, whereas in the carcinoma, the weight is usually 100 grams. The other feature which helps to differentiate between the adenoma and carcinoma are the mitosis, necrosis, or the vascular invasions, or the invasion of the fat, etc. Adrenal cortical carcinomas rare as compared to adenomas. Hereditary genetic syndromes where the people are more prone to adrenal cortical carcinomas. But of the dietary or the other habits, smoking is the another one which is implicated for the adrenal cortical carcinoma. The most common sign and symptom are because of the excess of the steroid hormones, which causes the Cushing syndrome. The other may be the mass effect. Sometimes the tumors are large, compress on the other organs, or there may be pain, there may be the hemorrhage, there may be hemorrhage in the tumor, or there may be the patient may complain with the abdominal fullness. And rarely the carcinoma can be detected incidentally when the patient is investigated for some other. As compared to the adults, the carcinoma in children, they are usually symptomatic. They produce some excess of those especially the steroid hormone, some virilizing features. Grossly, the tumor is very hemorrhagic in case of carcinoma, but adenoma, they are yellowish, well circumscribed. In the carcinoma, microscopically, there is a lot of pleomorphism. There be cells may become monomorphic. There is increase in mitosis. There may be vascular invasion outside the tumor. There may be capsular invasion, fat invasion. The prognosis depends upon the grade of the tumor. Usually the 5-year survival is 37 to 47%, and most of them they present with the hypercortisolism, then the prognosis is bad. The stage of the disease is also important. The people who present with the later stage or the advanced stage or more than 50 years, they have worse prognosis. Recently, many studies have graded the adrenal tumors, and according to WHO, they can be low grade, they can be high grade, depending on the number of mitosis. If the number of mitosis is less than 20 per 50 high power field, then they are low grade. If it is more than 20 per 50 high power field, then they are high. High grade tumor has worse prognosis as compared to low grade tumor. Now, sometimes there may be hyperplasia or the adenomas. Adenoma is actually more common than the hyperplasia of the glomerulosa, which is the small nest of cells just beneath the capsule of the gland. Aldosterone levels are raised, which causes the suppression of the renin-angiotensin system and decreases the plasma renin activity. In a majority of the cases, as I mentioned, is the adenoma, 80% of the cases, and less than 20% of the cases, there may be hyperplasia of the glomerulosa. 80% of the cases causes the secretion of the aldosterone, and this is known as the Cone syndrome, and this is very important cause of surgically correctable cause of hypertension. The children or the adults who present with the hypertension and the adenoma is detected when it is excised, the hypertension will revert back to normal. There may be hyperfunctioning of the reticulata, that is some defects in the excess of these hormones, the sex hormones, which causes either virilization or feminization, and that the different causes have been implicated, and most of them are the enzymes defect, which leads to either the mineralocorticoids, glucocorticoids, or the sex steroid excess. Now, the other end of the adrenal diseases is the insufficiency. As compared to the hyperfunctioning, here the levels of the corticosteroids, they are low. When the corticosteroid levels are low, ACTH should be high, but it's not happening in these cases. The less of the steroid hormones that causes the hypofunctioning, and there are large number of causes of hypofunctioning. It may be something wrong in the adrenal gland, it may be something wrong at the pituitary. For example, after the surgery or the radiotherapy of the pituitary glands, many patients they develop adrenal insufficiency. There may be causes which are related to the adrenal, and many of them are the autoimmune. There may be some congenital adrenal hyperplasia, metabolic failure of hormone production, some infiltrative diseases, for example, amyloidosis, sarcoidosis, hemochromatosis. In all these conditions, there is the infiltration of the adrenal cortex and there is hypofunctioning. The very important cause is the older age, is the metastasis, especially from the lungs, which is usually bilateral. Adrenal insufficiency may be acute or may be chronic. Sometimes the patients are on exogenous steroids, and when there is a sudden stoppage of the steroids, that leads to acute adrenal insufficiency. For example, in children, when there is meningococcal meningitis, there is a hemorrhage in the adrenal, there is a disseminated intravascular coagulation and shock. Many of these patients, they die. Sometimes there is in premature children, there may be massive bilateral adrenal hemorrhage which causes adrenal insufficiency. But of the chronic causes, the most important is the autoimmune, which is known as the Addison disease. Some may be infections, especially the histoplasmosis and tuberculosis in India. Maybe the metastasis, I mentioned, lung, breast, lymphoma, leukemia, sarcoidosis, HIV, hemochromatosis, and amyloidosis. They can cause acute as well as the chronic insufficiency. Autoimmune adrenalitis is a condition that is the most common with 60 to 70% of the cases, and many times it is associated with the polyendocrinopathy type 1, where there is autoimmune polyendocrinopathy, adrenal hypoparathyroidism involvement, hypogonadism, pernicious anemia, this chronic mucocutaneous candidiasis, some abnormalities of the skin and dental enamels and nails. This is the case where both adrenal were showing hemorrhage, they were grossly enlarged, and microscopically it was necrotic. And these are the small organisms which can be stained with the PAS or with the silvermethenamine. These are the histoplasmosis. Histoplasmosis is a very important cause of renal insufficiency in India. Especially it should be suspected when the biopsies or the radiology shows a necrotic lesion in the adrenal, which are usually bilateral. So these are some of the causes of the adrenal hyperfunctioning or hypofunctioning. The other important component of the adrenal gland is the adrenal medulla. It is supposed to be derived from the neural crest or the neuroendocrine cells. It has two types of cells. One is the chromaffin cells or the other is the sustentacular cell. The sustentacular cells are the supportive cells, whereas the chromaffin cells, they are the functional, they produce the catecholamines. The most important tumor in adult is the pheochromocytoma, but in children is neuroblastoma. Neuroblastoma is a very important tumor in the adrenal medulla, mostly in children. They are calcified, they are large in size, they present as a mass, and that is a different subject for discussion. Pheochromocytoma, these patients, they usually present with the very abrupt and very high blood pressure, which is episodic. This is very important. As compared to other causes of hypertension, it is episodic. Patient may have tachycardia, palpitation, headache, sweating, tremors. These patients, they may have the increased myocardial ischemia, heart failure, renal injury, or the cerebrovascular accident. The treatment is alpha blockers, fluid replacement, and surgery is the ultimate mode of therapy. This is another example of surgically correctable hypertension one should remember. This hypertension, sometimes these pheochromocytoma like tumor which are functional can be in the paraganglioma, And when they are in the urinary bladder, some of these patients, they present with headache during micturition. This is a very good sign to suggest that this tumor is in the urinary bladder. Earlier there was a rule of 10. That means that 10% of these pheochromocytoma or the paraganglioma are familiar. They are more commonly seen MEN2A, 2B, neurofibromatosis, von Hippel-Lindau disease. 10% are extrarenal, 10% are familial, bilateral, and 10% are biologically malignant. 10% arise in the childhood. The diagnosis is very simple: to measure the urinary excretion of free catecholamines or their metabolites, PMA. And when these levels are high, that's very suggestive of pheochromocytoma. This is the gross example. Pheochromocytoma, as I mentioned, they excrete the catecholamine. When these catecholamines they oxidize, then the formalin or coming in contact with the air, the color is brown or mahogany color. Grossly, they are well circumscribed, but there may be areas of hemorrhage. And microscopically, they have very characteristic appearance, what we call the gel vellum pattern. Small nest of cells separated by the thin vascular channels. And if you do the staining for these tentacular cells, they are S100 positive. Whereas this is another example showing very classical gel vellum pattern, the small nest of cells separated by these fibrovascular wrapping. And this can be well demonstrated by some reticulin stain. This is the reticulin rich, which are the blood vessels of the fibrovascular tissue, and the cells in the small nest, they are reticulin poor. These cells, they are strongly positive for chromogranin, synaptophysin, and maybe for the other neuroendocrine markers, CD56, PGP 9.5. But remember, these are negative for cytokeratin as compared to the epithelial neurocarcinoid tumor, which are more of epithelial phenotype of neuroendocrine. These tumors, they produce the catecholamines, which can be demonstrated by different means, which are the peptides which cause the hypertension. Now, malignancy, to indicate whether this tumor is a malignant or the benign, most of them are benign. Very rarely they can be malignant. The only criteria which earlier people used to think is the metastasis somewhere. The other features, vascular invasion or the capsular invasion, are not the feature of malignancy. But recently there is some risk stratification, and some of the features which are taken into consideration for the risk stratifications are the invasion. Invasion means the vascular invasion outside the tumor. It may be the adrenal capsular invasion, periadrenal fat tissue invasion. There may be architectural variation. Normally, as I mentioned, they are the gel vellum pattern, small nest of cells, usually very homogeneous or the pleomorphic. But in architectural pattern, when these groups, they become irregular, they are enlarged, they are confluent cell nests or diffuse growth, that is usually indicative of higher grade. Then there may be cytological variation. Normally these cells are large polygonal, but when they become spindling, small cell, or the small cell with the high nuclear cytoplasmic ratio, the cells become more monotonous, or there may be sometime extreme pleomorphism. That is also indication of cytological variation. Necrosis, usually we don't get necrosis in this tumor, but whenever there is a focal or confluent or comedo-like necrosis, that indicates it's a higher grade. Proliferative activity, which may be mitosis or may be in the form of MIB labeling index. Now, some softer criteria are the tumor size more than 5 cm, coarse nodularity, absent of these hyaline globules, which are especially seen in the tumor which are usually associated with the genetic syndrome, vascular abnormalities, or the absence of sustentacular cells. They are the softer point which indicate higher grade. Now, the prognosis depend upon the resectability. If there is a complete resection, the recurrence is very, very rare. If there is an incomplete resection, there may be recurrence after many years, maybe. Then some of the genetical profile, for example, SDHB mutation. A tumor which shows the SDHB mutation They have highest risk of metastasis. They have shorter survival. The other prognostic feature is the metastasis to lung and liver. If there is a metastasis to lung and liver, the survival is shorter. If there is metastasis to the bone, the survival may be more than 5 years as compared to lung and liver metastasis. There is another entity which is known as the composite phaeochromocytoma. That means that if a tumor is pheochromocytoma and it is combined with a developmentally related neurogenic tumor like ganglioneuroma, ganglioneuroblastoma, neuroblastoma, or the peripheral nerve sheath tumor. They are usually common in adults, unilateral, rarely bilateral. Clinical features are variables, and when to suspect them. When the tumor in the adrenal, which is thought to be pheochromocytoma, is not showing the classical features of pheochromocytoma radiologically, one can suspect this tumor as composite phaeochromocytoma. They are located in the medulla, and the prognosis depends upon which is the second component beside the pheochromocytoma. So these are some of the tumors which are important in the adrenal. The neuroblastoma is also a very common tumor in the adrenal, mostly seen in children, but it itself is a separate subject, so it will not be covered under this heading. Thank you.